Hello, everyone. Welcome to the University of Toronto Joint Centre for Bioethics Seminar Series. My name is Andrea Bianchi, and I'll be the moderator for today's session. Our speaker today is Dr. Eric Mathison, and this seminar is entitled, What Should We Do with Coerced People? Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics YouTube page. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. Now, before I more formally introduce our speaker, I would like to acknowledge this land on which I and the University of Toronto operate. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and I am grateful to have the opportunity to play, work, and live on this land. So it is my pleasure now to introduce today's speaker. Dr. Mathison was a clinical ethicist for Alberta Health Services before joining as a faculty member at the University of Toronto Scarborough campus. He currently continues to do clinical and organizational ethics, consulting for health systems and companies in Canada and the United States. Dr. Mathison was a postdoctoral fellow at Baylor College of Medicine, and he has a PhD in philosophy from the University of Toronto. Eric's research interests include assisted dying, the goals of medicine, and clinical practice. So Eric, Dr. Mathison, on behalf of the Joint Centre for Bioethics, welcome to today's seminar, and I'll allow you to take it away.
Okay, thank you so much. Hello, everyone. Thank you all for coming. I'm going to use my platform here for one quick advertisement, which is that I am organizing a bioethics workshop in Toronto coming up in May, on May 17th and 18th. And I want to draw your attention to this right now because the deadline for abstracts is coming up on January 15th. So I suspect that some of you are sitting on a paper or an idea or an abstract that would be a great fit for the workshop. So if you are interested in that, head over to philevents.org and you can just search for Toronto Bioethics Workshop. The info will come up there. It would be great to either receive your abstracts or to have you attend in May. I also want to let you know if you're interested in following along with the slides, or if you want to download them, that I've posted them on my website, which is just ericmathison.ca. And if you go under research, it's right at the top there. Okay, so I'm going to preface this with this is a new paper. This is the first time I've presented these arguments. And I just want to say, I didn't set out with this conclusion in mind. And so the conclusion that I'm going to present today was not my kind of intention. It's just kind of where I think the argument goes. So I am very curious to hear your feedback or hear your thoughts, because I suspect that there's something going on that I haven't quite captured, and I'm keen to know what that is. So here's some background. I'm going to talk about informed consent, which is this kind of transformative thing that happens in morality. So if you think of somebody who's in boxing, somebody were to punch you in the face, that would be almost surely wrong in most cases. But informed consent kind of transforms it into a totally permissible thing. You agree to the boxing match, the other person agrees to a boxing match, totally fine. Then what they're doing is not wrong. Similarly in medicine, that if somebody were to remove your appendix without telling you or giving you any notice about it, that would be a serious wrong. It would be illegal as well. But through the magic of informed consent, it transforms that seriously wrong action into something that is totally permissible, morally speaking. Informed consent is also really important. It's this, really determines in many cases whether the action is acceptable or not in healthcare. So I'm going to read there are kind of different accounts of what the foundation or what explains the importance of informed consent. This is a passage from Honora O'Neill, who says that the ethical importance of informed consent in and beyond medical practice is, I think, more elementary than promoting autonomy. It provides reasonable assurance that a patient, or research subject, or tissue donor has not been deceived or coerced. So most people think about informed consent as one of its main properties is that it promotes autonomy, which it does. But O'Neill is going even further and saying that it's this kind of mechanism for at least giving reasonable assurance that the patient or the individual has not been coerced. The standard account of what it means to have valid consent, that there are 4 properties. The patient has to be capable of making a decision, have decision-making capacity. She has to be given the information that's material to her making that decision. She has to understand the information, figure out what it means, and be able to kind of manipulate it relative to her goals and values. And then, importantly, for my purposes today, the decision has to be voluntary. So if it's not voluntary, then that's considered a threat to valid consent. Coercion affects voluntariness. That if somebody is coerced, then that means that at least at a certain point, that voluntariness is going to be affected to the extent that it could invalidate consent. So if somebody, in the kind of paradigmatic case of somebody points a gun and says your money or your life, that person has been threatened to such an extent that their consent, if they hand over their wallet, that wasn't voluntary, and so therefore the consent wasn't valid. So that's just like the very basic sketch. I am just going to, like set aside all the questions about informed consent, about the different requirements and so on. I'm also going to note that there are lots of articles and books and so on that are looking at what coercion is, trying to figure out as a property, as a phenomenon, what does it mean for somebody to be coerced, and also looking at the morality of coercion. In what cases, if ever, is it permissible to coerce patients in healthcare or others outside of healthcare? Today, if you're aware of that literature, you know that there's lots of stuff, lots of different theories about it. Today, I'm just going to try to be as theory neutral as possible. So I have some views about what the correct account of coercion is, but I'm trying as much as possible to kind of set those aside because that's not my focus here today. But I realize that in doing that, if any of you are aware of that literature, then things that I'm going to say that it could be have implications for different stuff. So once again, you can follow up with me in the Q&A or afterwards if you're interested. I want to know if you assume that we know for a fact that we have a patient who has been coerced, then what? What do we do with that? What do we do with that individual, or what do we do with that information? So whatever preferred account you have of coercion, let us assume that has taken place. The patient has been coerced. Then what? What are we supposed to do about that? This is, I'm going to describe a case for you to remain a philosopher in good standing. I'm going to describe this case very thinly. It is loosely based on a clinical ethics consult that I had a while ago, but I've changed some of the details as thin as they are. So bear with me. But partly why I've done this is because I mention kind of some treatment options, but I'm just going to describe them as just 2 options without giving the details, so that if you do know more about that, about what the treatment options would be, that's not going to kind of like lead you in any one direction, because that's not my focus. So here's the case. There's a patient in his 50s. He's got heart failure. So he's seriously sick, needs intensive care. A meeting.
I didn't get that. Could you try again?
Oh, sorry. Sorry.
No need to apologize.
Okay, sorry about that. So in a meeting, the patient is told the diagnosis, what the situation is, and there's a cardiologist, there's a surgeon, an intensivist, and the patient's wife is there. And the cardiologist is describing the heart failure and presents 2 options, 2 treatment options or 2 interventions. I'm just going to call them A and B. And I'm going to say that A and B are on a par. Now, in fact, the 2 options, there are pros and cons, so they aren't exactly identical. And depending on what the patient's preferences are and things that he cares about, he might well prefer A or he might well prefer B. So it's not kind of necessarily flipping a coin. However, from the clinical team's perspective, both of them are reasonable options to have on the table to present. They're not kind of strongly advocating for one or the other. That's what I mean by on a par. What happens is that after the cardiologist finishes describing the situation and describing what the two treatment options are, the patient's wife says, "You're going to get treatment A. Otherwise, I'm taking the kids and you'll never see us again." This is basically what happened. This part of it is basically what happened in the consult. I was at this meeting when this happened. So, after the meeting, I spoke to the spouse, and she gave me some context about what was behind it. And so I don't want like, this wasn't kind of out of the blue or like malicious. She had a kind of justification whether this was the right like best way to approach it in the context of their marriage and so on. I'm not gonna deal with, but she gave me some context that helped me understand where it was coming from. I said to her, so are you serious about this threat? And she said, "Oh yes, I'm totally serious. I will do this." I then later on spoke to the patients, and we talked about how the meeting went. And I said to him, "Do you think your partner is serious?" And he said, "Oh yeah, I absolutely believe that she's serious. I could tell in the meeting." Then he also said that he didn't want to lose his family, that this was a serious threat in the sense or for the reason that really cares about his relationship with his wife and his kids. So he takes this as kind of a serious issue. So I think that the facts of the case are such that coercion occurred, basically whatever account of coercion you subscribe to. This is going to meet the definition. There's a serious threat, going to influence his decision. I think it is also uncontroversial to say that it affected his voluntariness. All the other healthcare providers were concerned about the effect that it would have on his ability to make a voluntary decision. And to the extent that I think that it threatened him giving valid consent, that if he said, "Okay, well, given this threat, I'm going to go with A," that the healthcare team would have good reason to think that he had been coerced into that decision, that he hadn't made the choice voluntarily. And I want to mention as well that none of the other informed consent criteria were affected. So he still had decision-making capacity. All the information that was provided to him, otherwise would have been sufficient for him to give informed consent. He understood both the kind of nature of the diagnosis and the treatment options, and also that he understood what the threat meant. So there were no kind of misunderstandings or any interference with his decision-making capacity. I also just want to flag that in some ways, this is a bit of it's not a unique case, but there are some features of this case that I just want to flag before I go on. One of them is that there are actually three options that the patient now has to decide between if that's what's going to happen. That he has a choice between A and B, which are both reasonable, or he could do nothing. So in other cases of threats, like your money or your life, there are only two options, and that changes or might change the assessment. And also that A and B are both reasonable. So the threat has not taken all the reasonable options off the table, that there's still these two reasonable options. So exactly what impact these features have, I think is a kind of a bigger discussion, but just want to notice them because not all coercion cases are going to be like this. Okay, so that's the case. That's what happened. Now we want to know. So now what should happen in this situation? How do we proceed? This is what the team wanted to know from me. Like, how do we get around this, or how do we move on from this? So I'm going to walk through the options as I see them. And I want to point out at the start that I don't think any of them are that great. They're all kind of have downsides. But what I'm going to start with are some that we should just take off the table immediately, that I just don't think are plausible. So the first one is that we should just not give treatment. We can just not proceed with any kind of intervention on this patient. The case for this is that he can't give valid consent. So if you think about the boxing case that I gave before, if somebody can't give valid consent to a boxing match, then the boxing match should just not go ahead. So maybe analogously, therefore, any kind of treatment should not go ahead. But I think immediately we can see that can't be right, because he really needs the treatment. So just to say that he's blocked off now from being able to get access to this treatment because of the coercion, that can't possibly be right. And I came up with a little ditty that care shouldn't get worse because you've been coerced. So that's like Eric's fourth law of bioethics or something like that. So can't be the case that that he just doesn't get treatment, has to have heart failure until he dies of it or whatever, just because of the coercion. The second option is that, well, we can remove the coercion. And the case for this is that this would be a reasonable option in many other cases. So if we knew, for instance, that a healthcare provider or kind of some other third party was coercing the patient, then the reasonable intervention to take would be to remove the coercion, either by transferring the patient somewhere else, to a different hospital or to a different unit, or to like have the healthcare provider replaced, something like that. So there are going to be many cases that are unlike the one I'm dealing with, because we'd be able to remove the coercion. But this is not one of those cases. So I spoke to the spouse and said, so do we really have to go through with this threat? Can you just can we like take a different approach? And she said no. There's no other kind of practical solution, that transferring the patient to another hospital, that wouldn't work. The patient still wanted to see his spouse. So he didn't want to have her banned from the hospital, not that would help anyway. So there's really no kind of practical solution that's going to help. Okay, so those are both off the table. I just, they're either impractical or unworkable in another way. So the third option is that we could use a substitute decision maker. Now, this kind of I think maybe sounds a bit strange, but to motivate this is what happens in other cases where informed consent is impossible. So if you imagine if we have an incapable patient, a patient who doesn't have decision-making capacity, then the process step that we take is to find a substitute decision maker. And that could also be the case, depending on the circumstances, about poor understanding or other situations. So maybe what we should do is, if it's an involuntary decision, that we should use a substitute decision maker as well. Substitute decision maker might be able to think more clearly, or just kind of process the information in a more neutral way. And so maybe that would lead to a better result. But there are a bunch of problems with this. The first problem is that there's also a kind of impracticality concern. It can't be his wife. His wife is the one threatening him, so she can't be the one to decide. So we'd have to find somebody else, have him assign a substitute decision maker, and try to find another one. That's going to be pretty difficult. But it's also, more seriously, I think, even if we could find another SDM, is that this will further limit his autonomy. The problem with coercion in the first place of this sort, the worry that we have, is that it prevents him from making a voluntary decision in line with his values. And so if we then say, okay, well, the solution that we've come up with is that you can't decide about this at all, but somebody else now is going to decide what's going to happen to you, then that's a further reduction of his autonomy, which seems to be like we're making it worse, not better. And so I think that that's a serious reason against it, even if it were workable. Another problem, though, and here I should say that I think that this applies both to using a substitute decision maker, but also an option that I'm not going to have as a separate list, but something like figuring out what his authentic preferences are and then acting on those. So we can imagine if there were a way that we could know what he would have chosen before the threat took place, like which way he was leaning or what he would have decided. Maybe we could do that. And so that would get around the problem of how the coercion has affected his decision making. So I think that both of those options, using an SDM and authentic preferences, kind of face the worry that I'm about to present, which is that we want to know, well, like what would the SDM actually be adding in this situation? So suppose like a feature of the case is that the spouse is going to follow through on the threat if he doesn't get treatment A, kind of no matter the reason. So suppose it were the case that even if we had an SDM and even if the SDM chose treatment B, then the spouse is still going to follow through on the threat. So like a kind of very serious and kind of global threat. In any world where he doesn't get treatment A, I'm going to follow through on the threat. Well, it seems to me that in that case that this is material information to the decision making that the SDM should take into consideration. So if the SDM knows that one of the effects of you have option A or you have option B, but you should know that one of the effects of choosing option B is that spouse is going to leave, that it seems to be a consideration that the SDM should take into account. So it's not really clear. The patient is already capable of he's reasoning in the same kind of way. He's dealing with the same information. So it's not really clear that adding an SDM is getting anything new if we're adding something new. The threat here is relevant for the patient's values and best interests as well. So even if it were, if we say the SDMs typically have to make decisions in line with the patient's values if known, or wishes if known, and if not, in the patient's best interest. Well, we know that the patient's value is that he wants to stay in the relationship, he wants his family to stick around. So acting on those would say you should choose to have treatment A. But as a best interest thing, now, again, like setting aside concerns about like the how this marriage is going, setting aside those concerns, that given that he really cares so much about the relationship, that perhaps it's in his best interest for him to have A as well. Another problem, I'm just going to mention this one in passing, is that if that's true, like if the SDM should be influenced in this way, should take it into account, then maybe the SDM is being coerced as well, is being affected from kind of this threat. And that would be really strange because it means that there's no way out of the coercion. It kind of permeates everything, even to other people who would be substitute decision makers for this patient. Okay. So that brings us to option 4, which is proceed as usual. And by proceed as usual, I mean that we should just ask the patient, okay, well, what do you want to do given the facts as they are, given the situation? We can't, presumably you still want treatment. We can't get rid of the coercion. A substitute decision maker is not going to work. Authentic preferences are, kind of, maybe we don't have a way of figuring out what they are, but also that it raises those other problems. I don't see anything, other kind of realistic options, but let me know if what I'm missing. So the next option is just, well, we should just still seek out his consent. And this is, in fact, what I think is the right thing to do in this case. And it's based on a powerful argument, which I will now give you, which is that all the other options are worse. As I've described, I think that refusing or not proceeding with treatment is worse. Using a substitute decision maker is worse, and it's just not possible to get rid of the coercion. Okay, so this is the thesis or the argument that I want to make, is that whatever is going on, this is perhaps an unusual coercion case, but there are going to be other ones like it. And there's a case for that we should still seek out his consent. The first argument, I think, is that I guess the first argument is that it's better than the other options. The second argument is that he can still weigh the options in light of the threat. So as I said, his decision-making has not been, or his capacity, sorry, has not been affected. He's still capable, and he understands what has changed. So as the nudgers might say, the choice architecture has influenced his decision such that, now that he has more reason to choose treatment A. But he's capable of weighing those things, even in light of the threat. We might say that it's not a good thing, all things considered, that the scales have been kind of tipped in favor of A, but he's still able to kind of weigh things. So that's an argument in favor of still letting him decide for himself. It also seems to me more strongly that it would be wrong not to get his consent. That I just can't see a pathway where using any other method, that using a substitute decision maker or two-doc rule, any other approach, given the stakes of this decision for his health and for more broadly his values, that it would be acceptable in any way to proceed without his consent. And so we need his consent in order to proceed. On the other hand, it isn't valid consent. It seems that this is a case of coercion. It's a case of, there's not just minor coercion, this is a serious threat. And voluntariness is one of the conditions of valid informed consent. And so shouldn't we conclude then, that's what the puzzle is, shouldn't we conclude that he's not able to give valid informed consent because it's an involuntary decision? And so this is the puzzle. Okay, so that brings us to valid consent. Okay, so my claim is that the patient's consent is still required. That is not just the appropriate thing to do given what the other options are, but it's still a requirement, because I think proceeding with any kind of treatment without his consent would be wrong. And I mean consent. I don't think that this is a case of just merely following his preferences, or that it's a case of assent. I think that he is weighing the options. He's capable of doing that. He has the information. He understands it. So I think that we're not just kind of doing what he would have chosen. We don't know what he would have chosen. So we are getting his consent. It seems to me that the mechanism is kind of the same one that we would usually think of when we think of informed consent. Okay, but how can this be right? How can proceeding with this be ethical? That's the dilemma, is that the conditions of informed consent say that this isn't a that voluntariness is a requirement, but that he's if not involuntary, then it's affected to the point where his any decision that he would make is not going to be a voluntary decision. He's going to be strongly influenced, it seems, by the threat. So that, if any, seems like what the voluntariness condition is supposed to be capturing. Should say as well that it actually is it doesn't really matter whether he ultimately chooses A or B. If he chooses treatment A, then we'd worry that he's just doing that because of the coercion, that he's kind of pressured into choosing A when he otherwise might not. But the point about coercion is that it's, or the point about voluntariness is that it's affected kind of across the board. So I think that even if you were to say, no, given all the facts, I still want to go with treatment B. I'm just willing to take. I care about B so much that I'm willing to take the downside of what the consequences of that would be. I still think that we should have concerns about his voluntariness. So I think voluntariness is about partly what this is pointing to is that voluntariness is in part about the reasoning, about how the person gets to the choice, and not just about kind of the circumstances. So how can it be ethical? How can we proceed? Well, I think that there are two options that we have available. The one is we can actually say by voluntariness, we mean something that isn't quite captured by this case. So he's being influenced in some way, to be sure. The coercion still matters, but for all that, he's still acting voluntarily. And if you know about the coercion literature, or Beecham and Childress have this discussion in Principles of Biomedical Ethics that they think that coercion that rises to the level of invalidating consent, they use a phrase that the individual is controlled by the threat, and so I think by that they mean that there's like a psychological control, that the person can't think clearly in a way that they otherwise could. So it's not kind of a cool reflection of the different options and weighing the pros and cons and then deciding which one to do. They're controlled by it. The threat is so salient that there's a real sense in which they couldn't. The person coerced couldn't do otherwise. And so given how I've described the case, that this is not that. And so voluntariness, maybe what we want to say then is that whatever is going on in this case, it's not affecting voluntariness to the extent or in the right way. That's an option. And that would solve the problem for us, because it would mean that we could conclude that even despite the coercion, he's still acting voluntarily because he's able to weigh the options in kind of a rational way. The other option is to conclude that voluntariness isn't necessary for valid informed consent in all cases. So this is actually the one that I think I'm more tempted by, because looking at this case, it seems inescapable to me, the conclusion that his voluntariness is affected by this threat. And I think that this is one way of seeing this, is that if you imagine an even more extreme, even a more serious threat, such as it is, that even in those cases, that he would still be able to kind of decide what he wants. I guess as we crank up the level of the threat, it seems like his voluntariness is getting more and more affected, such that we want to say that he's not really, whatever voluntariness is capturing, that it just doesn't seem like he's got it in the same way that he did before the threat took place. An uncoerced patient who's just freely choosing among the options, where there's no kind of influence that a threat would make. So it seems to me that voluntariness is affected, and just dismissing it, of saying, oh, no, the patient is actually capable of making a voluntary decision in this case, just does not seem plausible to me. And so this does have an implication, I guess, about coercion theories, which is that I think that saying that the patient has to be controlled in the way that Beecham and Childress described, they don't really describe it in a lot of detail, but if we say that that's what the bar is, and that this person doesn't meet it, just doesn't seem to me like it's capturing the right account for informed consent. I think that this guy his voluntariness has been affected. And I think it's because the threat is serious. I think it's been affected to the point where we would worry about whether he can consent. Okay, so I think that we should go the other way. I think we should conclude that that his voluntariness has been affected, but either there are different types of voluntariness going on, or that in cases like this, whatever like this means, that voluntariness of this sort isn't necessary for informed consent. So if we ask the patient, we go to his room and say, sorry that you've been threatened, we can't do anything about it, let's talk over the options again, what would you like to do? I think that his voluntariness has been affected, but I think he's still capable of giving informed consent, which means that voluntariness of this sort, whatever that is, the type that's been affected here, it isn't necessary for informed consent in all cases. That brings us back to O'Neill's point, So she says that the ethical importance of informed consent in and beyond medical practice is, I think, more elementary than promoting autonomy. It provides reasonable assurance that a patient, a research subject, or a tissue donor has not been deceived or coerced. And if the argument is persuasive that I've given today, then this is mistaken. This is incorrect. That informed consent, in some cases, maybe in general, the general approach has this effect. But I think I've described a case to you where the patient has been coerced, and yet informed consent is still possible. All of this, however, should not be taken to mean that the coercion that took place was permissible, or that that it doesn't matter at all. I think instead what it means is that the explanation for the wrongness of the coercion, assuming that this coercion was wrong, isn't always because it invalidates consent. And this is, I think, a more general point that we can generalize in other ways, that if we know that a patient has been coerced, and we know that that could affect voluntariness, then it might be, it could be wrong in every single case. That's a kind of question to explore. But if we shouldn't reason to think that, oh, because it's informed consent is still possible, that doesn't mean that it was wrong to coerce the person. Just like I think that if you pressure somebody, it could still be wrong to pressure the person, even if they're still capable of making valid informed consent. So, I'm dripping with time here. So back to our question, what should we do with coerced people? I think in some cases this sort, and I think that there's a question about how much this generalizes. I think the thing that we should do is nothing. It doesn't change what the action is. We should still proceed as though the coercion hasn't taken place. Let the patient decide for himself, even in light of the threat. So back to the case. Well, essentially what happened is that was the recommendation, that the patient was able to make a choice, went with treatment A, and that's the way that it went. So I think this means, or I think the conclusion we should reach is that the patient was coerced, and he was able to give valid consent. So thank you very much. We've got lots of time, so I'm keen to hear your questions, and thank you for attending.
Thank you so much. Yes, we do have lots of time, which is wonderful. So we can take our time and work through questions, comments, concerns, anything that that anyone has picked up on or thought about during your presentation. Personally, I found that very intriguing and certainly relevant to the work that I do and to some of the thinking through these complex cases and the fine lines that exist in our work. So I will, before I actually jump to the questions, I would like to highlight that folks who are on the line right now can put questions into the YouTube chat. But if you aren't logged into YouTube, or if you just want to ask a question anonymously, then you can do so by emailing jcb.ea@utoronto.ca, and that'll be passed right along, and we'll make sure to ask Dr. Mathison the question. All right. So with that being said, so there's so one question that came in is just could you not? So in relation to this case and this person who was coerced, but of course the recommendation that you gave was around I guess how much that coercion should weigh into what we actually do, and we're going to proceed accordingly. But could you not? This is a question. Could you not consider that the person in the case is still a rational agent, taking into account an extra piece of information or a value other than the medical ones that are actually affecting his heart? And then it's just noted that particularly if there is an equivalence between the two choices medically. And if there was, then perhaps his wife wouldn't be so committed to one course of action.
Yeah, thank you for that. So I think that this is kind of what the puzzle is getting at, is that I think he still is a rational agent. He's capable of weighing the pros and cons, and it might be a feature of the case that because there are two reasonable options, that's doing some work. But I think that there's, like in other cases, if we think of the gunman case, who says your money or your life, well, you're still a rational agent in that case, capable, imagine somebody who's kind of calm and collected, who's able to weigh those choices and say, oh, okay, well, I'd rather have my life. And so they give over the money. Now, maybe that's still what we should do, but I think we want to say in that case that that person has clearly been coerced and they didn't consent to it. And so that kind of transformative thing that happens with informed consent that makes it okay hasn't taken place. So I agree. I think the agent is making a rational decision. What I'm trying to figure out is that like how the transformative part of the consent can still be possible given what's going on.
Thank you so much. And I think that actually nicely feeds into the next question, which is just how much do things change if A is worse than B? Like if it's a lot worse, then might your response in regard to the coercion change, in regard to whether he is still a rational agent change, just taking those two options into consideration. Yeah, if A is a lot worse than B, then would things change significantly as a result?
Yeah, and I think that that's the kind of more generalized case that have to do some more puzzling about because I don't think it is just a matter of that A and B are both reasonable. I think that like imagine that A is a little bit worse than B, that might kind of tip the scales still in favor of A given the non-medical features that the patient cares about. But then I'm still curious, actually, even in the like most serious case, like the mob comes and threatens the person, like threatens his life in a very serious way. If you do, there's only one option on the table. If you don't get this, then whatever, something really bad is going to happen. And you've definitely been coerced. I would say that just like the gunman case, that that the consent has been invalidated. But then what do we do? It's still the same puzzle. Should we, we can't not give him the treatment. He's like otherwise going to die, but we can't just, get rid of the coercion, suppose, like the mob will find him wherever he is. I don't think a substitute decision maker makes sense in that case. And even if we use a substitute decision maker, they should still go with the, take the mob into account. So I think the same problem gets generated. And that's like, maybe I chose this case because of its, because it's like kind of based on a situation I encountered. But I think the problem is actually more, is worse than than the way I presented it, because that, there's still this question of what should we do in mob cases? That'll be my next talk, I suppose.
Sounds good, and I'm sure we'll welcome you to do that. Just JCB being a welcoming place. Okay, so in relation to, I guess, question one, which is just considering whether this person is still a rational agent, right? Taking into account an extra piece of information or value other than the medical ones. Someone just noted that they agree, and that it seems like, and I think this is kind of the question that maybe, or the comment that we'd value your thoughts on, is just it seems like a relational autonomy lens could maybe be one that applies here.
I would love to know more about what the lens, how it would apply. So I think that's right, that like that's that it would show that we are not making these decisions in a vacuum, that we can be influenced by other people. I think that relational autonomy gives us actually this useful tool to show that that there are ways that we can influence each other. And sometimes sometimes I get clinical consults that are framed as coercion, but then when I kind of learn more about what the provider's concern is, it's about kind of influence. It's about a family member saying, well, like if I were in your shoes, I would do this, or I think you should do that, but not in a way that involves a threat or rises to anything like what I've been discussing here. And I think the relational autonomy does a good job of capturing that there's, we just influence each other and can have these effects. I say I want to go for dinner at this restaurant, and my partner says she wants to go for dinner at this other restaurant, and then we kind of sort it out. So I think that's helpful in other cases, but I'm, I think I'm, maybe missing what specifically, or the way it would specifically be able to address in this case.
Yeah, thanks so much. I mean, my interpretation of the question was very similar to yours, just around how maybe relational autonomy and just the way in which we do make decisions, not making them in a vacuum, is presumably relevant to this and a lot of other cases. But certainly, the person who asked that question, if you do want to elaborate, expand, then please feel free to do so, and then we'll certainly jump back to that so that we can address it.
I guess just to say that, like, I don't think it should be the case. I think it would be like if the relational autonomy, if the move is supposed to be that, well, we influence each other and this is just another case of influence, so, not really bad coercion or something like that. I don't think that's the conclusion that we want to reach, which is not, I'm not saying that's what the questioner was meaning to imply. But there's still a kind of, the open question about, I think that some types of influence are clearly wrong, or clearly affect decision making in a way that we want to avoid. And so that's what I'm trying to puzzle through.
Yeah, thanks so much for the clarification there. A comment came in just, of course, thanking you for your presentation and asking for some clarification in terms of what you're referring to in terms of substitute decision makers, in terms of just the complexity of this case and how it may be approached, applies specifically to Ontario law. And then bouncing off of that, if so, then are you saying that a substitute decision maker could actually be involved in cases of coercion, even if the patient is still capable? So maybe that, if there is a person who's capable, then to what extent would or why would an SDM actually be involved or permitted to coerce in the way that they are?
Yeah. Okay. Thanks. Yeah. So I'm not making any claims about what the law would say, or that I think that this is actually what I'm hoping this case shows is that we have a very well developed process in the case of incapability. So informed consent is not possible because the patient is incapable. We have a really nice process for that. Find an SDM, defer to that person. This is what personal directives and advance requests and other sorts of things. So that's all kind of laid out. But there's really no process that I can find. I've never, in all the coercion literature that I've looked at, I haven't found where people say, okay, but suppose coercion has happened, here's what the process should be in the way that it is for substitute decision makers. Yeah. So I don't think it would be, I'm not making any claims about the law, but ethically speaking, I don't think it would be appropriate to use a substitute decision maker for the reasons that I've given here. But that just shows that there's kind of this paucity of available options, that I just don't know what else we could do. And so I think we're kind of stuck with using with going to the patient anyway, which I think in this case is okay because I think that's the right thing to do. But in cases where it was less clearly the right thing to do, I still think that it could come out on top.
Thank you so much. And Dr. Mathison, I'm very glad that you did not leave just 5 minutes for questions, because the questions are flooding in. So,
Right.
yeah, that's great. So this is interesting, actually. So do you have any thoughts on, of course, the case that you presented, it focuses on this person's wife really doing the coercing and that influencing the outcome and the reflection about all of this. But do you have any thoughts on the moral differences that may exist between coercion by healthcare providers and coercion that is an influence of family members?
Yeah, sure. So I think that because healthcare providers have specific responsibilities as healthcare providers, that I think that changes the situation. This is actually another, I hate to keep mentioning Beecham and Childress, but they give another, in their discussion of coercion, they give another example of, they think that coercion is sometimes morally acceptable. The example that they give is a patient who is declining treatment, refusing to have treatment, and the provider says, well, if you don't accept this treatment, then I'm gonna sever our relationship. Now, I don't think that, it's not obvious to me that that's the moral thing to do. Maybe it could be in some cases, but the point, I think, is that there can be, I think it's possible to have cases where coercion might be acceptable, and without invalidating consent. So I think that the law is sometimes like this, that if I speed, then I'm going to get fined if I get caught. And so in that way, there's a threat, and that forms a type of coercion. But I think that in that case, I'm still consenting. I'm still capable of making a voluntary choice about how fast I drive. But it's an influence. So I think that maybe like the difference then between a healthcare provider and a spouse or a different kind of family member, that the healthcare provider there are more kind of limitations on what they may reasonably do than what it would be for a family member. But they're complex beyond that.
Thank you so much. So the next question, so there's a couple of parts, but I think that yeah, perhaps I'll read it out, and then if you want me to kind of separate the questions, go through them again, then just say the word. But yeah. So the first part is just what do you do in cases where a patient is being coerced without being allowed to ask questions or having full information, I presume, from the medical team in this case? So what if the coercing person actually disallows the patient to ask any other questions, and therefore there's this false belief that is deriving the coercion? Um, and so those are the first two pieces, and then the third question that I think bounces off of those is just, what if the doctor felt very strongly that option B actually works a lot better than option A, for example? And then I guess if questions aren't being permitted by the coercer, then yeah, what do you do in these sorts of cases?
Oh man, yeah, there's a lot going on in that way. So okay, so in my case, I'm saying that only voluntariness is affected, none of the other requirements of informed consent are affected. In the description, I think that some of the other, the information and understanding requirements are also affected, and so you really only have capacity. And so. I guess I don't know. I don't have a clear thought about this. I guess it would depend on by the coercion, what the threat is supposed to be. I will say that there are certainly cases where family members are acting inappropriately or interfering in such a way that it is appropriate to have them removed from the decision making, and at the extreme to not allow them into the hospital, because their influence on the patient is so serious that we have concerns about it. But that's only, I suppose, when there's no kind of threat attached to it. Now, what if I guess the part two is about what if options A and B are not actually on a par. And so that was, I guess, similar to another question that came up before about this sliding scale, yeah, I guess I don't have I don't think there's a clear-cut answer. I think that it gets muddier, but for sure, for interfering with understanding and information, if it's not combined with a threat, then that course of action would be different than the one I've presented right now.
Thank you so much. And yeah, I think that final bit of the question was certainly responded to for different questions. So that's perfect. Yes, and we're doing very well for timing as well. So one other question came in is just around the extent to which coercion may be permissible in a setting like research. So if a research participant is unlikely to benefit from participation in research, for example, like a phase 1 clinical trial, yet they're being coerced to participate, due to, and there's a similar threat being made, let's say, to the one that you raised in your case, then because it's research, ought that be treated differently? Should the outcome look different, or would we potentially do nothing and just say, no, we're going to seek consent in that case?
So I think it depends a bit. One thing I'm realizing with some of these examples, that I think that the coercer makes a difference. So if you imagine it's a healthcare provider who is recruiting people and has a dual role, and that person says, if you don't participate in this research, then I'm going to cut off treatment and it's going to be a lot worse for you. And so that's how they get participants to sign up. Then I think so in that case, the kind of transformative power of informed consent doesn't take place. That doesn't make it, or it means that it's not acceptable for, the person is not actually giving valid consent in that case, because they're being coerced. I think that's like the kind of standard approach to coercion. And I think in that sort of situation, the intervention would be to give that patient a different provider, or move them to a different hospital, something like that. Now, I suppose we could construct a case where it's had more similarities, where we can't kind of do all those things, and then it would be, I think, clearly wrong. But yeah, maybe there is still situations where proceeding we'd be kind of forced to say that that was still the best case if it was. But yeah, I think in that case, it seems like what the intervention, the thing that we should do in response to learning that information is more clear cut. We should get rid of the coercion, have the patient sent somewhere else.
Thank you. We have one more question. We have 2 minutes. Perhaps we can just try to hammer through if that works for you, Dr. Mathison. So the last question, and this person says, "Hello, Dr. Mathison. Thank you for the informative and engaging presentation. Would certain acts of coercion, either by a healthcare or family member, be justified on paternalistic grounds?"
Yeah, I think that's what Beecham and Childress have in mind, is that there could be cases where making a threat to somebody to change the balance of the options, that could be justified when it's for their own sake. I think so. It could be partly for paternalism. It could be like justified on those grounds, but it could be for other sorts of things. So I think like vaccine mandates are coercive, but I think that those could be justified when the kind of stakes are a certain way. So I think coercion is not should not be off the table, and that's what makes it more complex. Is that just because there's coercion present does not mean that consent is impossible, and it doesn't mean that something immoral has taken place. That's a big part of the difficulty.
Thank you. That's wonderful. And I think that's the perfect question. It's the final question, but also the perfect one to end off on. And so it is, of course, time to draw today's seminar to a close. So a couple of very fast announcements before I thank our speaker. Just that our next seminar will take place on January 31st, so in a couple of weeks, featuring Dr. Rashad Rehman, where he will be discussing the topic of intersex does not refute the sex binary. To sign up to receive our weekly seminar reminder and event digest emails, please email jcb.info@utoronto.ca. I think this is being put into the YouTube chat for those who want to reach out. And with that being said, just Dr. Mathison, thank you so much on behalf of all of us here. Really appreciate you sharing your thoughts, your case, your openness to discussion as you grapple with a really important and challenging topic. So thank you very much for coming.
Yeah, thank you, everybody. Thank you, Andrea.